Welcome you all for the surgical lecture series in Trident ERPM Academy. Today's topic is Colangio Carcinoma. This tumor originating in the epithelium of bile duct. More than 90% are adenocarcinomas. Classify into intrahepatic and extrahepatic cholangiocarcinoma. Intrahepatic 10% and extrahepatic 90%, whereas extrahepatic again classify into hilar and distal cholangiocarcinomas. Risk factors are chronic inflammatory conditions such as primary sclerosing cholangitis and hepatitis C viral infection. There are congenital cases such as cholidoccal cyst and Caroli's disease. Parasitic infection also contributing to cholangiocarcinomas like liver flukes. Chemical agents such as vinyl chloride, asbestosis, and thorium dioxide also contribute. And post-surgical causes are very rare. So biliary enteric anastomosis is one of the causes. When it comes to intrahepatic cholangiocarcinoma, the clinical features are very minimum. Generally, they are asymptomatic and usually the incidental finding on an imaging. If at all, the symptoms are right hypochondrial pain, loss of appetite, and low-grade fever. Jaundice is a very uncommon symptom. When it comes to investigations, there are a whole lot of investigations available, but in general, if you ask about investigations, you should able to say we generally assess the patient's fitness for surgery and we should come to a diagnosis and also assess the operability. So these are the three areas that we concern about when we are doing investigations. Having that in mind, we'll move on to one by one. When we do ultrasound scan, what we want to see is the intrahepatic and extrahepatic duct dilatation, presence of a cholidoccal cyst, cholelithiasis, and cholidocholithiasis. With multiphasic abdominal pelvic CCT or MRI with contrast, there are no pathognomonic features of intrahepatic cholangiocarcinoma, but doing that, we can assess the resectability, the relationship of tumor to major vessels or biliary tree, if present, a satellite lesions, and presence of non-regional lymph nodes or distant metastasis. There are several tumor markers. Out of those, CEA and CA19.9, these are not specific for cholangiocarcinomas, but the levels can elevate in other benign conditions also. These we do as a baseline value. One is to see the tumor burden, and also it is important in the follow-up to assess any recurrence. And you should keep that in mind. The CA 19.9 levels can be high as a false high value in obstructive jaundice patient. Alpha-fetoprotein level is also another tumor marker which will be elevated in hepatocellular carcinoma. In a patient with CLCD, where you get a diagnostic difficulty, whether this is intrahepatic cholangiocarcinoma or hepatocellular carcinoma, the alpha-fetoprotein level will be important. The upper GI and lower GI endoscopies are important in a case if you are suspecting a hepatic metastasis that can mimic intrahepatic cholangiocarcinoma. In such situation, we need to do upper GI and lower GI endoscopies to see any primary GI malignancy. Biopsy is not mandatory, and if the tumor is resectable, but if tumor is not resectable, it's always mandated. The diagnostic laparoscopy is another way of investigation, but this is where you can't find any metastasis in an imaging. The management of intrahepatic cholangiocarcinoma, if resectable, always the goal should be R0 resection with negative margin. Even with negative margin, the 5-year survival rate is 40%. The type of surgery include anatomical resection or non-anatomical resection with hilar lymphadenectomy. There's hardly any place for orthotopic liver transplant because there's no proven survival benefit. Post-resection, R1 will offer observation or chemotherapy, whereas R2 can offer chemotherapy or chemoradiation with local regional therapy. The follow-up every 6 months up to 2 years and annually after that. If tumor is unresectable, the treatment options are chemotherapy or chemoradiotherapy with local regional therapy, such as external beam radiotherapy, and arterial directed therapies such as transarterial chemoembolization, or the best supportive care will be another option. We do same thing for the metastatic disease also. When it comes to cholangiocarcinoma, the clinical features are obstructive jaundice, right upper quadrant pain, loss of appetite and loss of weight. In your examination, hardly you will be able to palpate the gallbladder. When it comes to the investigation, again, the same thing apply. So the triphasic liver CT and CT pelvis and chest basically to stage the disease, and also the MRCP with CEA and CA 19.9 level. As I said earlier, the biopsy is not mandatory if high suspicion of imaging. If unresectable, then again, the same theory will apply where you need a biopsy. And also the liver function test and the IgG4 level is important to rule out autoimmune cholangitis, as it can mimic extrahepatic cholangiocarcinomas. Little bit about Bloom-Blart classification. It based on the tumor location, the extent of bile duct involvement, and also portal vein invasion and hepatic lobe atrophy. So there are three grades, T1, T2, and T3. When it comes to resectability, you need to have the intact contralateral arterial and portal and biliary flow to say a resectable tumor. Basically, T1 and T2 tumors are compatible with resection. When it comes to Bismuth classification, as you can see, the type 1 tumor below the confluence of the left and right hepatic ducts, whereas type 2, the tumor reaching the confluence of the left and right hepatic ducts. In type 3A, the tumor involving the confluence and the right hepatic ducts. In type 3B, there's tumor involving the confluence and the left hepatic duct. In type 4, the tumor involved the confluence and both the left and right hepatic ducts. So this classification is important, that sometimes that this can be asked in your MCQs. When it comes to hilar cholangiocarcinoma management, the resectable tumors, the prerequisites are it should not be a T3 lesion. So always T3 below, and there should not be any non-regional lymph nodes, and there should not be any metastasis. The patient should be fit for surgery, and always you should take a MDT decision prior to surgery. So we consider external biliary drainage or ERCP if the patient is jaundice, especially the bilirubin level more than 15. We consider external biliary drainage. Or if the patient need any nutritional optimization, if the surgery getting delayed for more than 2 weeks, we generally consider putting an EBD. And also, if the low future liver remnant, so preoperative contralateral portal vein embolization is another option. When it comes to surgery, the complete resection with negative margin and regional lymphadenectomy is the treatment of choice. And post-operative, R0 resection require observation or chemotherapy, whereas R1 resection needs chemotherapy or chemoradiotherapy. And follow-up, CT chest, abdomen, and pelvis every 6 months up to 2 years, and then annual assessment. For unresectable hilar cholangiocarcinomas, the biliary drainage along with a stent insertion by ERCP or PTC, followed by a biopsy, require MDT decisions to take on for chemotherapy or chemoradiation, or to plan for a best supportive care, or sometimes photodynamic therapy is an option. Distal cholangiocarcinoma, the diagnostic evaluation is same as for hilar cholangiocarcinoma. Distal cholangiocarcinoma management, if resectable, the mid-cholangiocarcinomas, the bile duct excision with frozen section assessment of proximal and distal bile duct margin, but the most of the time, it ended up with a proximal side with a hepatic resection and distal side with a pancreatic duodenectomy, commonly called the Whipple surgery. For distal cholangiocarcinomas, always pancreatic duodenectomy with biliary reconstruction with Roux-en-Y is the treatment of choice. The postoperative follow-up as for hilar cholangiocarcinoma. For unresectable or metastatic tumor, The management again, same as for cholangiocarcinoma. Let's move on to some MCQs. Here, in this question, a 24-year-old man present with obstructive jaundice, the imaging revealed that the cause is most likely to be a cholangiocarcinoma against a background of a choledochal cyst. Which pattern of disease is most common? So, the answer is D, the single fusiform cystic dilatation of the common bile duct. So what do you know about choledochal cyst? Choledochal cyst is most commonly present in the first 12 months of life. There is a classic trial in 50% of the patients who carry choledochal cyst. These are the right upper quadrant pain, jaundice, and right upper quadrant mass. If you go through the Todani classification, the most common type is type 1, which accounts for 70 to 80% of the uh, patients. And type 4 is next common with 20%. So the the correct answer is answer D. So the next question. A 62-year-old man has a cholangiocarcinoma occluding the common hepatic duct and extending into the right hepatic duct. How is this categorized in Bismuth classification? So this is very easy for you. We have already discussed the Bismuth classification. So the answer is answer C, the type 3A. So you can go through my previous presentation so you can better understand. Let's move to the next question. Which of the following statement is true regarding the cholangiocarcinoma? The survival rate are better for the distal cholangiocarcinoma compared to intrahepatic cholangiocarcinoma. Obviously, the answer is that. When you take the cholangiocarcinoma as a whole, the surgical resection of cholangiocarcinoma is the only therapy that offers the prospect of a long-term cure. So, the distal cholangiocarcinoma, out of these, the distal cholangiocarcinoma carries the best prognosis, whereas the early presentation of a distal cholangiocarcinoma with early resection warrants the best prognosis out of all. If you take hilar cholangiocarcinoma, with all the patients as a whole, only 15 to 30% of the patients are candidates for surgical resection or transplant. So therefore, the distal cholangiocarcinoma has a better prognosis. So that concludes my short lecture on cholangiocarcinoma. So we'll be meeting with another topic sooner. So until then, thank you.